afternoon, everyone. My faculty mentor was Dr. Crawford Downs. None of the authors have any commercial financial relationships or interests. I'd like to acknowledge members of the Downs Lab, especially Daniel Turner, Chester Calvert, Lisa Hitchcox, Ryan Whitley, Anna Edmiston, and Kevin Bryan, and of course, Dr. Downs, for all the assistance. And these are the current research support grants used for this project. Glaucoma is the second leading cause of blindness worldwide. There are more than 50 million people affected. It's a multifactorial disease, and although we do not know about the precise pathogenesis of it, intraocular pressure and advancing age are the most consistent independent risk factors in most major prospective clinical trials. Lowering of intraocular pressure, even in the normal range, is the only clinical treatment that has been shown to retard the onset and progression of glaucoma. But what is the true intraocular pressure of a patient? Our knowledge of intraocular pressure is based on office-based measurements that we do, the gold standard for which is the Goldmann's applanation tonometry. These snapshot measurements are taken in the office every 3 to 4 months, and they dictate therapy. In spite of widespread knowledge in literature that IOP is not a static parameter, rather it demonstrates fluctuations, and if measured over a period of 24 hours, it can fluctuate up to 6 millimeters in normal people and much more in patients with glaucoma. Intraocular pressure is thus a dynamic parameter. It has a circadian rhythm, and to know its true effect on ocular tissue, we don't know the true effects on ocular tissue because of the lack of continuous monitoring technology for patients. Glaucoma is more than intraocular pressure. There's more data in the literature that vascular risk factors do contribute to the progression of the glaucomatous process. Large epidemiological studies like the Lales, Baltimore Eye Survey, Barbados Eye studies, and clinical trials suggest that ocular perfusion pressure, blood pressure, and ischemia may all contribute to glaucoma risk. Ocular perfusion pressure, in a sense, is basically the difference of intraocular pressure and the arterial blood pressure. Low OPP has been shown to be a significant vascular risk factor and is associated with higher prevalence as well as increased progression of glaucoma. And recent studies show that even fluctuations in perfusion pressure are a major risk. But OPP fluctuations and the relationship to intraocular pressure have not been studied. The purpose of this study was to characterize bilateral intraocular pressure and perfusion pressure via continuous radiotelemetry in 4 non-human primates, and to test the hypothesis that bilateral ocular perfusion pressure differs between the primates but is similar between fellow eyes within animals. At UAB Center for Ocular Biomechanics, we address this critical barrier in understanding the true character of intraocular pressure and ocular perfusion pressure by developing this fully implantable radiotelemetry system. This is the picture. Okay, well, it doesn't have it. The picture is, this allows bilateral measurements, and it's a fully implantable system. The picture on the top shows the 2 IOP transducers for the 2 animals. The transducer is screwed onto the bony wall of the orbit, and it has an aqueous tube which enters the anterior chamber. This transducer is made of a thin deformable titanium membrane, and it's housed in a titanium casing. So when the thin membrane comes in contact with the aqueous, it denotes these deformation, and there are strain gauges at the back of this membrane which reads it as an electrical impulse, and this is sent via the transducer lead to the transmitter and battery package, which is implanted in the abdomen. So in all, this is a schematic of the system. From the eye, the information goes to the transmitter and battery module in the abdomen, from where it's wirelessly transmitted via an antenna in the animal's cage to the base station, where the IOP, aortic blood pressure, and body temperature is digitally sampled 500 measurements per second, 24 hours a day. The data is then sent to the data acquisition, control, and storage, where it's later processed, filtered, and quantified. This is representative 12 seconds data from the telemetry system and showing the dynamic nature of intraocular pressure at the right and the left eye, the aortic blood pressure, as well as the EOG. The larger fluctuations are the blink, and the smaller fluctuations are the saccades, which the system captures very well. So we had 4 non-human primates, all young rhesus macaques with similar body weight from ages of 6 to 8 years of age. We had bilateral working implants in 3 of them and a unilateral implant in 1. And these are the number of days the data was collected. The system, as I said, records 500 measurements per second of bilateral IOP, EOG, and it calculates ocular perfusion pressure over 24 hours. The IOP transducers and ocular perfusion pressure is calibrated every 2 weeks using anterior chamber manometry and ophthalmodynamometry, and we compensate for drift continuously using post-processing software. To calibrate the IOP transducer, every 2 weeks the animal is anesthetized. The anterior chamber is entered with a 27-gauge needle, which is connected to an infusion set with a sterile infusion bottle. There's an inline pressure gauge. So the manometry bottle is initially brought to 5 millimeters of mercury, and at that point, the telemetry IOP reading is read. The manometry bottle is then raised in 5 millimeter increments up to 45 millimeters, and we continuously read the telemetry IOP reading at that point. This gives us an idea of the drift the system has. Over a month, the drift is never more than 3 millimeters, and in the calibration files, we calculate the drift and accurately calculate the intraocular pressure. The data is then analyzed. We filter out the noise and signal, and then average the IOP and OPP in overlapping 1 hour and 5 minute windows for each day. To calibrate the perfusion pressure at the same time when the animal is anesthetized and we are calibrating for the IOP transducer, we are also using the Heidelberg Spectralis OCT to image the optic nerve head and the arterial blood pressure at the same time. This is time synced to the telemetry IOP and aortic blood pressure. So once we are raising the manometry bottle height, the first instance of central retinal artery flutter means central artery diastolic pressure is equal to ocular IOP, which is in this case 30, and we keep on raising the manometry bottle higher till complete collapse is noted, which means the systolic central artery pressure is equal to IOP. So in this way, we can continuously get ocular perfusion pressure measurements. This is a picture of the 1 hour window averages for intraocular pressure. We can see that all the animals are essentially, the fellow eyes are similar. The intraocular pressure is higher during nighttime. There's a peak in the morning, and the different animals are different, but the IOP is consistent between the fellow eyes. Looking at the perfusion pressure in 1 hour window averages, we again see there's a peak in the morning around 6 o'clock. The ocular perfusion pressure increases at least 5 millimeters on waking, and overall is 5 to 10 millimeters higher during waking hours. Perfusion pressure is lower during the night. Looking at the histogram for 1 hour window averages, the OPP distribution fluctuates widely between all 4 non-human primates. The animal in red tends to stay at a lower perfusion pressure around 35 to 40 for most of the day, while the animal in green has a perfusion pressure in the higher ranges around 60 to 75, while the orange and the blue animal are somewhere in between, which shows that each animal has a different distribution, and both eyes are kind of similar. Looking at the 5-minute window averages, again, they follow the similar pattern, which makes us think, is this a possible indicator of inherent animal susceptibility? Is the animal with perfusion pressure at the higher range having a better perfusion and a lower risk for glaucoma versus the animal in red who tends to stay at a lower perfusion pressure? This is a plot comparing the perfusion pressure and the intraocular pressure together, which shows that both the IOP and the OPP, they peak during the waking hours. IOP is highest during the nighttime, although the perfusion pressure is lowest during the nighttime. There are differences between the two eyes, but they do follow similar patterns. In conclusion, continuous telemetry helps demonstrate the dynamic character of IOP and ocular perfusion pressure. Snapshot measurements are therefore unlikely to characterize the true IOP, OPP, or the fluctuation on any time scale. We need telemetry systems that can be tolerated for more than 24 hours. There are contact lens-based measurements that can be put on the eye, but they're not tolerated for more than 24 hours. Although intraocular pressure has a similar pattern between fellow eyes, there's some asymmetry which could be a source of eye-specific susceptibility to glaucoma. The average perfusion pressure varies between primates, but it's consistent between fellow eyes. Ocular perfusion pressure is highest in the afternoon and the evening and is lowest during the night. These differences are significant, which may put the non-human primate with a lower perfusion at a higher risk for ischemic damage at elevated intraocular pressures. OPP could technically be reduced due to either low blood pressure or high intraocular pressure. The relative contribution of the biomechanical versus the vascular risk factors are likely eye-specific, and they cover the full range of IOP and OPP values. The intraocular pressure, ocular perfusion pressure relationship, and the glaucoma relationship is murky, and this could be induced in our part due to the lack of understanding of IOP-OPP relationship and the dynamic effects on the optic nerve head, biomechanics, and perfusion. Measurement of perfusion pressure could be beneficial in glaucoma patients with intraocular pressure in the normal range. Glaucoma is conceivably a disease of multiple pressure. It's more than intraocular pressure. The role of intracranial pressure is still not clear, but we are funded to add the cerebrospinal fluid pressure measurements in the new telemetry system in the non-human primates. It's also it's not known how the supine position affects intraocular venous pressure and consequently how it affects perfusion pressure.